السلام عليكم ورحمة الله وبركاته. معاكم دكتور محمد صالح من Edu-PIC. النهاردة هنتكلم عن Diaphragm Assessment with Ultrasound. Contents, importance of diaphragm, causes of diaphragmatic paralysis, when we suspect diaphragmatic palsy, how to diagnose diaphragmatic palsy with ultrasound, how to assess ventilator-induced diaphragmatic atrophy using ultrasound. Importance of diaphragm. Diaphragm is the most important inspiratory or respiratory muscle. It contains two components, non-contractile central tendon and the contracting muscle fiber. It's innervated by the phrenic nerve coming from C3 and C5. Contraction of the diaphragm decrease the intrapleural pressure, generates positive intra-abdominal pressure, contributes to 3/4 of the inspiratory volumes at vital capacity. This is the anatomy of the left and right phrenic nerve. I'm not going to dig into details, but this is how to imagine the course of the left phrenic nerve and the course of the right phrenic nerve. Causes of diaphragmatic paralysis: the neurologic causes and myopathic causes. The neurologic causes like spinal cord transection, multiple sclerosis, amyotrophic lateral sclerosis, cervical spondylosis, poliomyelitis, Guillain-Barré, phrenic nerve dysfunction, which may be by compression or cardiac surgery or blunt trauma or other causes. Myopathic causes, you can see limb girdle dystrophy, hyperthyroidism or hypothyroidism, malnutrition, and the dermatomyositis and other causes of myopathy. This is a video showing the normal fluoroscopic movement of the both bilateral copulae of the diaphragm. You can see here both the left copula and the right copula going down together with inspiration. Okay, when we suspect diaphragmatic palsy, we suspect diaphragmatic palsy if we have failed extubation, if we have difficulty of weaning without obvious cardiac or pulmonary etiology, difficulty weaning the mechanical ventilation, of course. If you have a Hoover's sign, which is paradoxical thoracic movement, and we are going to have a video showing this. Decreased breath sound on the ipsilateral side, recurrent or persistent lung collapse, patient who had persistent need for nasal continuous positive airway pressure like CPAP, or if we have elevation of the hemidiaphragm on the chest X-ray after extubation. All these make us suspect diaphragmatic palsy. This is the Hoover sign. You can see the movement, paradoxical movement of the chest wall and abdomen. Diagnosis of diaphragmatic paralysis. You can suspect from the chest radiograph, as you can see here, the elevated right copula, which is significantly high, but this is not a sure diagnosis. We have to go for a further tool to confirm this diagnosis. We can use the fluoroscopy, but the fluoroscopy has some limitations because it requires patient transportation and you will use ionizing radiation. You will depend on the sniff test, which is showing paradoxical elevation of the paralyzed hemidiaphragm with inspiration. Here is another X-ray showing elevated right copula of the diaphragm, significantly elevated. Here another patient with elevation in the right copula. And here is a fluoroscopy that is showing moving normally left copula of the diaphragm, moving normally downward in inspiration. And here the right copula is fixed. It's not moving at all. How to assess diaphragm using ultrasound? We can assess diaphragm through two approaches. The first one is a subcostal view, putting the probe in the subxiphoid area and trying to get the two diaphragm clear, as we can see here in the this image. And here is a video that is showing that the left hemidiaphragm or the left copula is moving downward freely with inspiration, while the right one is fixed. It's not moving at all. You can see clearly. And if we go for the M mode, we put the cursor on the left hemidiaphragm, you can see here the excursion of the left copula with inspiration. Okay, and if you put it on the right side or the right hemidiaphragm, it's not moving, so it's showing a flat line. And here you can take a measurement for the this excursion with the end expiration and the end inspiration. What is the difference between them? And you can assess very well the diameter or the distance of excursion, which can tell you, is it a fixed copula or it is moving but it is not normal. Here is this interesting study that was published in 2021 in the Annals of Pediatric Cardiology, which is talking about early diagnosis of diaphragm palsy after pediatric cardiac surgery and outcome after diaphragm plication. It's a single center experience. And this study was showing the bedside ultrasonography using echo machine was 96.7% sensitive and 96.1 or 0.15% specific. You can notice how much it is specific and sensitive to use the ultrasound to diagnose the diaphragmatic palsy. And here we will talk about the second approach that we can assess, through which the diaphragm thickness, which is very important that you can predict the ventilator-induced diaphragmatic atrophy. The probe positioning to assess diaphragm thickness: first, supine position while reclining in bed at a 30-degree angle. The transducer was placed at the 9th or 10th intercostal space near the mid-axillary line and angle perpendicular to the chest wall. This is the probe positioning for the right hemidiaphragm, and this is for the left hemidiaphragm. And here you can see this image. You can see here the diaphragmatic pleura. Here is the diaphragm. This is the diaphragm. And here is the peritoneal pleura. And here we can take this measurement for these 2 points, which is showing the inspiration, and the B points, which is showing the expiration. And you can measure from here to here. Then you take the difference between both the 2 points at the end inspiration and the end expiration. Here also is an interesting study talking about ultrasound assessment of ventilator-induced diaphragmatic dysfunction in mechanically ventilated pediatric patients. This study showed done over 47 patients were enrolled, and the atrophy surprisingly was found in 30 patients. So 30 patient out of 47 has had this atrophy. And these are the measurement, and the next table is showing the difference between the thickness or the diaphragmatic thickness between the baseline and pre-extubation. You can notice here the thickness, baseline thickness 2.2, and before extubation it decreased to 1.95 at the end inspiration. And here also at the end expiration for the diaphragmatic thickness, it's also from this is a baseline 1.8 and this is 1.4. So here you can see the change in diaphragm thickness during the mechanical ventilation. Conclusion: diaphragm is the most important respiratory muscle, and ultrasound is easy, quick, safe, bedside, highly specific and sensitive tool to assess whether diaphragmatic movement or thickness. These are our references, and thank you.